So, coming to this topic, in the next 30 to 40 minutes, we'll be talking about approach to a case of neonatal anemia, different transfusion cutoffs, because giving platelet PRBC transfusion is one of the commonest intervention or one of the commonest procedure which we do in our NICUs. Although there are no evidence-based guidelines, but there are certain guidelines which one has to follow. And finally, I will talk about neonatal thrombosis, which we see both venous as well as arterial in NICUs, and it sometimes is quite challenging to treat such babies. So, as we all know that anemia and thrombocytopenia are quite common, especially in sick newborns who get admitted in our NICUs. And almost 50% of the babies who get admitted, they receive some form of transfusion. And the rate is as high as 90% in ALBW babies. That is, ALBW babies at least receive one transfusion during their admission. And although it's so common to give blood products in NICUs, but still there is no evidence-based consensus. Whatever little evidence is there, it is mostly expert opinion. But overall, the evidence favors that restrictive policy is better than a liberal one. First, we'll be coming to the RBCs, that is the red blood cells. Just a background about reticulocytes. So basically, reticulocytes are immature red blood cells which contain RNA and organelles in a reticular pattern. That's why they are called reticulocytes. They usually have a half-life of 1 day before they get matured into mature RBCs. And usually, high retic count indicates either hemolysis or hemorrhage. Since RBCs have a half-life of 120 days, the retic count is usually calculated as a percentage, and normal percentage comes out to be 0.8, 0.9. Now, the problem with reticulocyte count is that it is dependent on the hematocrit or hemoglobin. So, in cases of anemia or neonatal anemia, we can get a false high reticulocyte count, although the marrow is suppressed or is not giving an appropriate response. Therefore, we need to know the absolute reticulocyte count. The advantage with absolute reticulocyte count is that it gives us the number of the new RBCs produced in the last 24 hours, and it overcomes the inherent pitfall which is there in the reticulocyte count, because it also takes into account the RBC count. Absolute reticulocyte count is calculated as percent of reticulocytes multiplied by RBC counts. And there is also something known as corrected reticulocyte count, which is very important in evaluating neonatal anemia, because if the reticulocyte count is high, we know that the cause can either be hemorrhage or hemolysis. On the other hand, if absolute reticulocyte count is low, it indicates that there is a marrow failure. And if the corrected reticulocyte count is less than 2%, it is indicative of hypocellular marrow. Now, neonatal anemia is quite common, and it usually presents in the form of poor weight gain, tachycardia, tachypnea, increased oxygen requirement. And one thing which is very important in CBC to diagnose acute versus chronic hemorrhages, whenever there is hemorrhages chronic, for example, fetal-maternal blood loss or hemoglobinopathies, the RBCs become microstick. So on CBC, if we see a microstick and we have to differentiate between acute hemorrhage and chronic hemorrhage, always look for microcytic anemia, which is indicative of chronic hemorrhage. And in cases of severe anemia like HBH disease, the manifestation can be as severe as hydrops vitalis. What is important is that whenever we are evaluating anemia or any blood disorder, it's always important to send a sample or to preserve a sample before giving a transfusion. Otherwise, if we send samples post-transfusion, the results can be erroneous and it will not lead us to any conclusion. The common sampling for a neonatal anemia includes a CBC, retic count, peripheral blood film, blood group, of course, and the DCT. Now, some of the markers which indicate that the cause is hemolysis include, whenever there will be hemolysis, there will be rise in indirect bilirubin and a fall in hemoglobin. Also, we discussed that whenever there is hemolysis, the retic count will increase in order to compensate for that increased destruction of RBCs. Now, hemolysis can be either immune-mediated or non-immune-mediated. And the simple test to differentiate between immune versus non-immune hemolysis is doing a DCT, which if is positive, it signifies that it is a immune-mediated hemolysis. And whenever we examine these babies, apart from the anemia, we'll also find hepatosplenomegaly. Now, a word about sometimes, because now NTD is quite commonly used in cases of Rh negative pregnancies, but we have to remember that in 3 to 6% of the cases, this NTD can cross the placenta and can give a false DCT positive, even in the absence of hemolysis. So whenever we see any baby with anemia, we have to first do the absolute retic count or the corrected retic count. If the retic count is decreased, it tells us that there is a marrow failure. In premature babies, the most common cause of marrow failure is anemia of prematurity. The other causes includes Rh incompatibility, where we see a chronic anemia, or it can be very rarely. If the anemia is persistent without any cause, always look for congenital hypoplastic marrow syndromes like diamond black fun. On the other hand, if retic count is increases, it shows that either there is hemorrhage or hemolysis. Now, the hemolysis, as we discussed, can be either immune mediated and non-immune mediated. And the simple test is DCT. If the DCT is positive, we have diagnosed that it is an immune mediated hemolysis, apart from clinical clues of hemolysis, which includes jaundice, hepatosplenomegaly. The common causes of immune mediated hemolysis in neonatology is major blood group incompatibility like Rh and ABO, and very less commonly we see minor blood group incompatibilities. However, if DCT is negative, we have to look at the CBC picture, that is whether the anemia is microstic or normostic or macrostic. We discussed that if the anemia is microstic, that is the CBC showing microstic anemia, either it can be chronic blood loss, which can happen in twin-to-twin transfusion or fetal-maternal hemorrhage, or it can be suggestive of hemoglobinopathies like thalassemia, like alpha and gamma. Usually, we all know that since there is a high percentage of fetal hemoglobin in neonates, so beta thalassemia usually does not present in neonatal period. However, if the CB is suggestive of normostic or macrostic, then we have to look at the shape of the red blood cells. And if it is spherocytes elliptocytosis, it gives us the diagnosis that it is either hereditary spherocytosis or elliptocytosis. However, if it is normostic and peripheral smear is normal, we have to rule out hemolysis, which can be either because of the enzyme deficiencies like G6PD, which is more common, and less commonly pyruvate kinase or hexokinase. Also, the infections, either viral or bacterial, can sometimes lead to hemolysis. Now, we should also know when to transfuse. As we already discussed that there are no clear evidence-based guidelines, but usually what we follow, or according to our NNF and IAP guidelines, for first 24 hours in stable baby, we follow a cutoff of 10. And for babies who are on uneased respiratory support, usually we try to maintain a hematocrit of 35 or more. Subsequently, as the baby becomes more mature, the threshold becomes low. Now, there are some other markers which can help us decide whether we should transfuse or not. One of them is serum lactate. We know that whenever there is anemia, there is decreased oxygen supply to the tissues, which leads to anaerobic metabolism, leading to increased lactate production. However, we should also keep in mind that lactate is not a specific marker for tissue hypoxia. Lactate can also be increased in sepsis or other conditions. Therefore, it is not a specific marker, but can be taken into consideration before we decide whether to transfuse or not. The other thing which has helped us in giving transfusion is NIRS. Although initially NIRS gave some positive results, but it is still, the values are so variable that still it has not found its place in day-to-day neonatal practice. And one should always take the clinical condition into account while deciding whether or not to give the transfusion. For term babies, for stable babies, we can maintain hematocrit up to 21%. And usually if the baby is asymptomatic, we can monitor these babies on OPD basis. However, if the baby is on any respiratory support, for example, he's on oxygen, but with an FiO2 of less than 30%, 35%, or he's requiring some form of respiratory support like CPAP, an IPPV, but the MAP is less than 6, in those babies, we tend to maintain a hematocrit above 30. If he's on higher support, that is a MAP of more than 6 on an IPPV, then we tend to maintain a hematocrit of more than 35%. For babies with congenital heart disease or requiring ECMO, we try to maintain more than 45%, because those babies the blood is not completely saturated, and therefore we try to maintain a higher hematocrit in order to avoid tissue hypoxia. These are some of the other guidelines, which are international guidelines, and this is just for the reference. We usually follow the previous guidelines. Now, the general principles while giving transfusion is that usually we give 10 to 15 ml per kg of PRBCs over 3 to 4 hours. We give over 4 hours. Smaller the baby, usually the duration should be on the longer side. And irradiation of PRBC is highly recommended to prevent graft versus host disease. And in preterm babies during transfusion, it is advisable to keep them nil per oral because of the risk of transfusion associated NEC. Coming to the platelets, again, thrombocytopenia is quite common, especially in country like ours, where the incidence of sepsis is as high as 10 per thousand live births. Although it is one of the commonest intervention which we do, but majority of the platelet transfusion in our practice are actually prophylactic. And because there is always a fear among the clinicians that baby may bleed. But the evidence has shown that there is hardly any correlation between the platelet count and the actual risk of bleeding. Babies who have less than 50,000 platelets, only 10% or 5 to 10% of the babies actually have a significant bleeding. To know the cause, usually we broadly classify thrombocytopenia into early onset and late onset. That is, before 72 hours, we classify it as early onset thrombocytopenia. And if it occurs after 3 days of life, we call it late thrombocytopenia. In majority of the healthy babies, especially the preterm babies, the cause of early onset thrombocytopenia is placental insufficiency. That is, mother who has chronic hypertension, preeclampsia, or baby's IUGR. Mostly this type of thrombocytopenia is not severe. The platelet count hardly goes below 80,000. And usually the babies are otherwise fine, stable. There is no evidence of bleeding. And there is a spontaneous recovery by the end of the first week. Now, when should we investigate in early onset thrombocytopenia? If baby is sick, the thrombocytopenia is very severe. That is, the platelet count is below 50,000. In those babies, if the baby is otherwise well, but the platelet count is 50,000, in a term well baby, we need to rule out NAIT, that is neonatal alloimmune thrombocytopenia. Whereas in sick babies, the most important cause is HIE. It has been seen that around 30% of the HIE babies can have severe thrombocytopenia secondary to marrow suppression, and it can be prolonged and severe. Late onset thrombocytopenia is very common in our setting because of the high incidence of sepsis, and the two most common causes include sepsis and NEC. And often the late onset thrombocytopenia is often associated with DIC. So always it is better whenever there is a baby with late onset thrombocytopenia, you should always do a coagulation profile to rule out DIC and prevent bleeding. Sometimes this thrombocytopenia is often protected. That is, even if you have treated sepsis, the platelet count tends to be low. So you don't need to chase these low platelet count if you have corrected the sepsis babies otherwise well. You don't need to chase the platelet count with antibiotics. If you have given adequate dosage, baby has responded, he is otherwise clinical stable. Majority of the times, whenever you follow up these babies, they will recover. That is, the platelet count will recover. Do not continue antibiotic just for the sake of that the platelet count is low. Now, as we discussed that in a stable term baby, one of the commonest causes of severe thrombocytopenia is neonatal alloimmune thrombocytopenia. It is usually because of the maternal sensitization to paternally derived fetal platelet antigens, because of which the mother develops antibodies and they are passed on to fetus. The problem with this type of thrombocytopenia, it can be very severe and it can have a dreaded complication of intracranial hemorrhage to the tune of 20%. And majority of, that is 80% of these intracranial hemorrhage can happen in utero as early as 20 weeks of gestation. Therefore, we have to be very vigilant in monitoring these babies. They may be completely asymptomatic. They may have a severe IVH leading to seizures, bulging fontanella, or there may be petechiae only. The management includes that such babies, first of all, should be regularly monitored. We need to get a scan done on day 1 of life and day 3, day 4, because at day 3, day 4, there is a max, that is the nadir occurs, whereas the platelet touches the bottom. So we need to do one scan at 4 times and one before the discharge. You need to ensure that these babies are monitored till there is recovery of the platelet count to near normal, and which usually happens towards the end of the first week. We usually give platelet transfusion whenever the platelet count goes below 25 to 30,000 with the compatible platelets. And if the thrombocytopenia is prolonged, that is, we have to give repeated platelet transfusion, then it is better to give IVIG, which decreases the need for subsequent platelet transfusion in the dose of 1 gram per kg for 2 days. The other common causes of thrombocytopenia in otherwise well-term babies, neonatal autoimmune thrombocytopenia, which is because of the maternal antibodies, either because of the maternal ITP or autoimmune syndromes like SLE. Usually, the severe thrombocytopenia is less common in this form of thrombocytopenia. Also, the good thing is that the incidence of ICH is low. However, this type of thrombocytopenia may persist for months, and whenever the thrombocytopenia is severe, that is platelet count is less than 30,000, we usually treat with IVIG first, that is 1 gram per kg for 2 days, followed by platelet transfusion. The other less common causes of thrombocytopenia includes congenital infection. In those babies, you have to look at other markers of intrauterine infections, which includes IUGR, abnormal eye examination, intracranial calcifications, dysmorphism, hepatosplenomegaly. Similarly, some syndromes, especially the trisomies 13, 18, 21, apart from the common dysmorphism which we see, they can have severe thrombocytopenia. Inherited thrombocytopenia should be suspected whenever the onset is early, that is during the first few days of life, and the thrombocytopenia persists beyond 7 to 10 days without any obvious cause. But the common causes include TAR syndrome, that is thrombocytopenia with absent radius, diamond black fan syndrome. Now coming to the approach, so whenever there is early onset thrombocytopenia, if the baby is preterm and otherwise stable, the commonest cause is placental insufficiency. We don't have to do anything, just monitor them. Usually they recover by day 5 to day 7. If the baby is a term baby and otherwise well with severe thrombocytopenia, think of two causes. One is NAIT, that is neonatal alloimmune thrombocytopenia. Remember to rule out ICH, that is intracranial hemorrhage, and monitor these babies till they have a normal platelet recovery. The other common cause is autoimmune thrombocytopenia, which is because of the maternal SLE or maternal ITP. If the thrombocytopenia is early and the baby is sick, then look for intrauterine infections, sepsis, and chromosomal anomalies. Late onset thrombocytopenia, the baby is usually sick and is often secondary to sepsis, which may be either bacterial or fungal, and NECs. Now, whenever there is a bacterial infection, the baby usually crashes like anything. But the fungal babies are more stable. They tend to have hypo and hyperglycemia, and thrombocytopenia is usually more prolonged. In late onset thrombocytopenia, if the baby is well, usually it is because of the thrombosis, which is often secondary to the catheter like PICC line, umbilical line, or medications. The common medications which cause thrombocytopenia includes our antibiotics, which we try to give to bring the platelet counts normal, or NSAIDs. Like reticulocyte count in anemia, the mean platelet volume is important in finding the cause for thrombocytopenia. Now, if the mean platelet volume is normal, it shows us that the thrombocytopenia is because of the decreased production. However, if the mean platelet volume is increased, it tells us it is because of the accelerated destruction, for example, which happens in sepsis and NEC. So for platelet transfusion cutoff, if the baby is otherwise stable without any evidence of bleeding, we tend to keep the platelets above 25,000. However, if the baby is having active bleeding or baby with NAT with previous sibling having a history of intracranial hemorrhage, we tend to maintain platelet count above 50,000. For any major surgery or procedure, the platelet count has to be maintained above 1 lakh. For CSF examination, we usually tend to maintain a platelet count above 50,000. These are some other international guidelines for platelet transfusions. Coming to the other blood product, which we again commonly use in our NICUs, is fresh frozen plasma. Now, the fresh frozen plasma contains almost all coagulation factors, including the labile factors, such as factor 5 and 8. Usually, we try to give FFP more as a prophylactic, which is not a correct thing, but we should usually give if the INR is more than 2, or PT or APT is more than 1.5 times the normal range, depending on the lab you are using. Also, rarely we use FFPs to treat congenital deficiency of some clotting factors if we do not have those specific factors available at that time. It is also used for treatment of DIC. Now, the dose is again the same, for example, as in PRBCs, that is 10 to 15 ml per kg, and it usually corrects the coagulation factors by 15 to 20%. What is important to remember that the effect of an FFP lasts for 6 to 12 hours. So it is time bound. So accordingly, you should give transfusion. For example, before procedure, before surgery, if you have to give, you should have to time the FFP transfusion. Another important thing to remember in FFP transfusion is that we use straight as an anticoagulant for plasma. So if you are giving rapid plasma, that is at the rate of more than 1 ml per kg per minute, it may be associated with citrate toxicity. Now, citrate itself can cause myocardial depression, hypotension, and abnormal coagulation. So you have to keep that in mind, that always give FFP slowly, not more than 1 ml per kg per minute. I've heard about neonatal thrombosis, although it is rare, but we do often see cases of neonatal thrombosis, both venous as well as arterial. The most common important risk factor for arterial thrombosis in neonates is intervalling catheter, like PICC line, central line, or umbilical catheters. Whereas in venous thrombosis, it is often secondary to sepsis, hypovolemia, or dehydration. Now, the neonate is inherently predisposed to thrombosis. That is, neonatal period is a prothrombotic state because we all know that our neonates have a higher hemoglobin, which causes increased viscosity of the blood, therefore more likely of thrombosis. The vessels are very narrow, especially when we compare it to the catheters which we use. So again, it leads to increased risk of thrombosis. Also, the neonates have low levels of proteins that are important in coagulation regulation and fibrinolysis. Some of the risk factors which predispose our neonates to thrombosis include asphyxia, sepsis, dehydration, and maternal diabetes. Renal vein thrombosis is something which is very common in babies born to infants with diabetes mother. Apart from these, there can be some inherent causes of thrombosis as listed here. Now, when should we investigate? Every case of thrombosis does not need to be investigated. We should only investigate if the thrombosis is very severe, unusual, or there is very extensive venous thrombosis, or there are very severe skin lesions, including purpura fulminans. In those cases, we need to send a complete thrombotic panel, which includes protein C, S, and antithrombin levels. However, we have to remember that quite often we come to babies come that the mother has history of thrombophilia and they come for testing. Remember that thrombophilia is rarely present in the neonatal period. So we do not have to investigate unless and until baby has symptoms suggestive of homozygous state. Otherwise, we don't need to investigate for thrombotic disorder during neonatal period. Same is true for factor 5 Leiden mutation or prothrombin gene mutation. Again, these disorders do not present in the neonatal period. Again, if the mother has these mutations, we do not need to investigate during the neonatal period. Coming to the treatment, if it is in secondary to central line, we have to keep in mind that do not remove the central line immediately because it can lead to the dislodgement of thrombus and can cause severe problems, including pulmonary thrombosis. So it should always, the catheter which is linked to thrombosis should always be removed 3 to 5 days after anticoagulation. For anticoagulation, we usually prefer low molecular weight heparin. Warfarin is not recommended during neonatal period. And always babies on heparin should be monitored for platelet count and anticoagulation. The duration usually is 6 weeks to 3 months, depending on the response. And usually thrombolysis is given only if we have an end organ dysfunction or one limb is at danger. Otherwise, we do not use routine thrombolysis in neonatal practice. Now, why do we prefer low molecular weight heparins? Is because there is less risk of hemorrhage with low molecular heparin. We can give it by subcutaneous route, so we do not need an IVSS. It decreases, it has got less risk of bleeding, so the monitoring is not too cumbersome, and there is also less risk of thrombocytopenia. The only disadvantage with low molecular weight heparin is that it has got a longer half-life compared to unfractionated. So in cases where you have to give short-term thrombolysis, for example, patient has to undergo surgery. In those cases, we can use unfractionated heparin. Otherwise, low molecular heparin is the modality of choice. The take-home messages includes that blood products should be used judiciously. They are associated with the complications, and there is no role of prophylactic, either platelet transfusion, PRB's transfusion, or plasma. Whenever you are giving these blood products, they are associated with some inherent risk factors, including infection, which can be life-threatening. So always monitor these babies and ensure that you have guidelines in place for your unit, and we should be followed strictly. Thank you.
Thank you, Dr. Akash, for such an enlightening presentation. So there is a question in the chat box. Mr. Akash is asking, what are the normal MCH values for the neonate?
We have a chart for that. I will share that in the group.